PAs and NP professions were essentially created in 1965. In the early 70s, as the professions were beginning to grow, they were encountering problems with reimbursement. There was no way to recognize them under the Medicare program other than what is referred to as Incident 2. Medicare has long had a policy that said we will pay for services provided by individuals under the direct supervision of a physician that would have otherwise been covered had they been provided by a physician. But then when you get out to rural areas, that meant you could only have a PA or a nurse practitioner in the same office as the doc. What happens if the doc leaves for the day or whatever? Beginning in the mid-70s, there was an effort to recognize PAs and NPs under the Medicare program. And organized medicine did not want anybody other than a physician to be recognized in their own right as a provider. At that time, the Appalachian Regional Commission was doing a lot of research on, what can we do to improve access to healthcare in rural areas? And they said, well, look, if we set up this program as a rural health clinic and we pay for a rural health clinic visit, and a visit can be done by a doc, a PA, or a nurse practitioner, technically we're not paying for PA and NP services. We're going to pay for a rural health clinic visit. Oh, okay. So you're not going to pay NPs and PAs? No. Their services will be covered, but we're going to call it a rural health clinic visit. And so that all kind of came together and led to the creation of the Rural Health Clinics program.
Rural health clinics are really interesting provider type. But because they're so different and the types of clinics are different, they don't always see themselves as a program. It is a designation that gives them access to a little better reimbursement that's volume appropriate for the clinics. When I first started, we had a few rural health programs, and the Rural Health Clinic program being one of them, and among the oldest of rural support programs.
It gave them recognition. It gave them the acknowledgement, more so than even just the dollars, but that the federal government was like, you have value, you have worth, and we recognize that value and worth in the healthcare delivery system.
So in 1977, when the program was authorized, there was relatively little use of physician assistants and nurse practitioners. A lot of payers didn't pay for them. There was some challenges to that. But it really brought about team-based care where we could bring in different level of providers to address the shortfalls of primary care services.
Rural communities, on the physician side in particular, struggled because the early assumption was that most people were going to have insurance from a commercial payer. And historically, Medicare and Medicaid did not pay as well as commercial insurance. And so the business model was, well, you're going to make enough profit on your commercially insured individuals to offset whatever losses you might experience from Medicare and Medicaid. You look at a rural community, and rural communities have a disproportionately high percentage of elderly relative to their total population, meaning you had a much greater percentage of your population were on Medicare. And so that model of offsetting, using profit from commercial to offset losses on Medicare didn't work. And so that was why they came up with cost-based reimbursement for rural health clinics. They said, well, look, cost-based is working. It's keeping the hospitals open. Let's use that same model for these rural clinics.
But the idea was that by paying them a cost basis at a better rate, they could then remain more viable, and it covered at least some of the fixed costs and the higher costs of providing service. So it's really about volume appropriateness.
It wasn't until hospitals shifted to the PPS that suddenly getting cost-based reimbursement for these outpatient clinics became significant, and then we saw a huge ramp up in the number of hospital-based RHCs. A rural health clinic is part urgent care, part prevention, part traditional primary care, because it is the primary point of contact for almost everything. The farmer cut his hand severely in the morning, put some duct tape on it, and 5 o'clock after working all day shows up and says, can you fix this? If somebody walked into my primary care doc's office with that, he'd be like, "We're calling 911. I'm not touching you, right?" But in a rural health clinic, that's what you do. You have to do everything. You're setting and casting bones. You're suturing wounds, you're debriding wounds, you're doing chronic care management because you've got patients who are, got chronic disease. So you're running the gamut of services. And so people need to understand that aspect of what they do. And that's what makes them so critical is that full breadth of services they're providing in those communities. And so, thousands of patients and thousands of communities have health care that I don't think they would have otherwise had were it not for this program. I went to work for the American Academy of Physician Assistants, and I was the first federal lobbyist for the PA profession. A lot of the PAs were specifically working in rural health clinics. And so I was increasingly getting calls from PAs who were working in rural health clinics who were encountering problems, and PAs who wanted to get a rural health clinic established who were running into problems. And so in the course of that, I would reach out to the Healthcare Financing Administration, which is what we know as CMS today, to try and help people find answers. But part of me is like, okay, isn't there an association? Isn't there somebody out there who I could call and get these answers? I had to go to the people in the government. And then I would hear from people say, well, I was talking to a consultant. And I thought, you shouldn't have to hire a consultant to be able to get basic information about a program that at that point was on the books for 10 years. And so we came up with this idea of starting the association to create a place where advocacy could occur, but more importantly, a place where people could come, get answers to questions without having to be a consultant or hire a consultant to do it. And what I've tried to do at NARHC is say our focus has to be on the patient. What are we doing and how does this benefit the patient? Because if we're doing something and it's not for the benefit of the patient, then we have to ask ourselves, why are we doing it?
It really has been almost 45 years now of providing services to people in rural America, which is great. Except it was a slow program to grow. And it's important to understand the Rural Health Clinic program was not about serving solely the uninsured. It was a program targeting geographic access for Medicare and Medicaid beneficiaries. So it was really about people who couldn't get services based on where they live. It was slow. They expected somewhere around 1,500 clinics in the first couple of years. It languished around 600. And it stayed there, and with some changes over time to make the program more tenable to providers and to clarify some of the regulations and to sort of alleviate some of those fears, the program is now over 5,000 clinics.
The creation of the Federal Office of Rural Health Policy was really critically important to this story. The administrator of HRSA announced that he was going to create an Office of Rural Health. And so they drew people from HCFA, they drew people from other offices in HRSA to establish the original Office of Rural Health. So I went up and to meet with them. And the first thing they said was, what kind of new programs, what kind of new things should we look to do? What recommendations do you have for what kind of things we can do to help rural America? And I said, before you embark on creating a new program, why don't you look at what you can do to improve an existing program, the Rural Health Clinics program? And they were like, well, what's that? And so I explained to them what the Rural Health Clinics program was. And at that point, when you look back on the original history, the Congress projected that there would be 2,000 RHCs within the first 7, 8, 9 years of the establishment of the program. We were here in the mid to late 80s, and there were 400. And so I said, why not look at why we didn't achieve the numbers that we thought we would achieve, or the Congress thought they would achieve, and what can we do to get to those numbers? And so they crafted a letter that they sent to every hospital, rural hospital in the United States or whatever. I forget how they got their list. but basically said, hey, there's this program, and there were only 4 hospital-based RHCs, but they said, you really need to look at this RHC program because there may be opportunities, particularly now that you're under DRG and PPS and it's changing. And they sent that out. And that was really critical as the first effort on the part of the federal government to actually promote and encourage the establishment of RHCs.
I think the fact that this program has driven a lot of our thinking about how to support rural providers through enhanced reimbursement, understanding that cost-based that fee schedules and traditional prospective payment systems don't do well for rural providers. I think that's an important lesson. The use of team-based care, and I think the importance of understanding how to modify a program over 45 years to make it relevant. And we've seen legislative changes, we've seen programmatic changes that have helped to make that program more viable. The lesson is true from rural health clinics, from critical access. These programs didn't start off being as widely and quickly embraced as we would have thought they were. But over time, each of those programs have been modified to make them more relevant for the current environment. And that's, I think, an important historical fact as we think about other ways of moving forward.
First and foremost, access to care. I mean, that this notion of primary point of contact, that how many communities wouldn't have healthcare in their community were it not for the existence of the rural health clinic.